Thank you. It's a pleasure to be here. So when I first thought about how to approach this topic of urine review for neurocritical care, I was a little confused as to how to go about doing this. So I started with taking the three most common disease processes that we see and going from there. As in everything, there's good news and bad news. The bad news is that there's nothing too earth-shattering. The good news is that everything that we've been doing for the last couple of years, we have data for now. So we're going to talk about acute ischemic stroke, primarily thrombectomy, which has changed in the last year or so, traumatic brain injury, which remains an elusive disease to actually make a significant impact for. The two topics that are going to be hypothermia and progesterone. And the last thing we're going to talk about is intracerebral hemorrhage and some new techniques or new management strategies that are coming forward. So for acute ischemic stroke, we sort of had a relatively long course in being able to actually do anything for this disease. As you know, in the 1990s, the standard of care was intravenous thrombolysis, which had some effect but no significant improvement for many patients. Enter into the early 2000s, in 1999, the era of thrombectomy and intra-arterial therapy. The first few device trials that we had were not really successful. With Multi-Mercy, Clotbust, Mercy2, and Penumbra. Eventually, we did some significant larger clinical trials in 2013 with IMS3, MR Rescue, and synthesis expansion. And all these trials were combinations of intravenous thrombolysis for acute ischemic stroke as well as the addition of thrombectomy. And all of those last three trials in 2013 were negative. But those of us in neurocritical care still felt that there was probably still a strong role for thrombectomy. We've all seen plenty of patients in our neuro ICUs that have done dramatically well with this. So that led us to doing more clinical trials, and then in 2015, 4 major clinical trials were all published. MR Clean, which was a trial primarily from the Netherlands, and they looked at a combination of stent retrievers within the first 6 hours of acute ischemic stroke. All these patients had vascular occlusion that was shown in a proximal vessel, such as the internal carotid or the middle cerebral artery. Very positive data from that trial. That trial was actually stopped early. There were 3 other trials that were happening at the same time that were pretty close to each other, but still had some differences. So then there was Escape, which was a trial that looked at thrombectomy up to 12 hours with known patients with known identified middle cerebral artery occlusion. The difference here was that they based the decisions to either go forward with thrombectomy based purely just on a non-contrast head CT, looking for early signs of ischemia. The outcome measured through the modified Rankin scale, which is a scale of 0 to 2, defines as a good independent functional outcome. As you can see, the intervention group did significantly better than the TVA group. Extend IA was another similar trial. It looked at, it actually used CT perfusion imaging in conjunction with collateral imaging and CTAs, and the trial included patients up to 6 hours after last known normal. The results there were even more striking, 71% functional independence compared to 40% with IV thrombolysis. Swift Prime was the last one that was done, and this was hyperacute with patients who presented within 4.5 hours. And they looked at primarily patients with either an ICA occlusion or a middle cerebral artery occlusion as well. So in the last year, we've had 4 really strong clinical trials that show essentially that if you combine all the trials, the number needed to treat is somewhere between 2 and 3 for acute ischemic stroke for thrombectomy, which is amazing. So that's really changed our amount of patients that we get in the neurocritical care unit and how we manage these patients and the new treatment paradigm. So the first key is to identify a patient with a large ischemic stroke, so proximal vessel occlusion. And these are going to be patients that have gaze deviation, hemiparesis, higher cortical signs such as aphasia or neglect, in addition to hemiplegia. The decision for IV thrombolysis is made on if it's still within the time window, either 3 to 4.5 hours. A CTA to confirm vascular occlusion, and then transferring to a stroke center as quickly as possible that can do thrombectomy. where our job sort of comes in as neuro-intensivist is really managing these patients from a hemodynamic standpoint after successful reperfusion. Official guidelines really have not been established for this, unfortunately, but if you look at the clinical trials that did this, all of them kept their blood pressures less than 160 systolic. Our practice is to usually keep them a little bit tighter, systolic blood pressures less than 140 for the first 24 hours to minimize reperfusion injury, but there's absolutely no data to actually suggest that. But most of these patients actually end up having really well autoregulation after they're reperfused. The area to move forward with this is still for those patients who are outside of that 6-hour time window that we sort of arbitrarily set up. And this is for a lot of these patients that have wake-up strokes, people that go to bed around 9 or 10 p.m. and then are found by their loved one at 6 or 7 o'clock in the morning with an acute ischemic stroke. And so this is a trial that's going on right now, and that's going to be thrombectomy based on CT perfusion alone. The next area and topic I would like to talk about a little bit is traumatic brain injury. So TBI is a very complex multifactorial disease, and there have been so many negative trials that have looked at each individual effect that we've tried: magnesium, progesterone, hypothermia. So it's a complex disease that's still in search of its holy grail for effective improvement in outcomes. So the two trials I'm going to talk about here are yet another trial for hypothermia and a trial of progesterone that was completed last year. So sort of in traumatic brain injury, when we think of ICP management and control, just a quick little review, we think of it as a three-tiered layer of strategy. So for ICP control, the first basic layer is going to be ICP sort of basics and protection. So elevation of head of bed to 30 degrees, avoiding cervical-venous compression, so trying not to do IJ lines in these patients if possible, maintaining normal capnia, avoiding fever, and mild sedation and CSF diversion if it's necessary. So that's basic tier 1 strategy. Tier 2 is if your ICPs are still elevated, addition of further CSF diversion is needed, hyperosmolar therapy with either mannitol or hypertonic saline, and then addition of increased sedation as needed. Tier 3 is when you're still having refractory ICP to all these above measures, and you add in neuromuscular paralysis, sedation to burst suppression, and hypothermia. Hypothermia has a lot of protective effects. We've been using it a lot for tier 3, but the question was, does it have a role for treatment sooner in the TBI paradigm trial? So Eurotherm was the most recent trial that was completed last year. Before that, there was a clinical trial, NABISH, which did not show a positive benefit to early prophylactic hypothermia. Eurotherm was a little bit different than that. We did all the patients had level 1 therapy, but hypothermia was the intervention arm, and patients were cooled to 32 or 35 degrees as they could tolerate it, and that was added to level 1. So it was early prophylactic hypothermia versus the control group in which only hypothermia was only added if they failed level 2. Unfortunately, what we found was that there was no clinical benefit of adding hypothermia at level 1. And so this was, in fact, if you look at the Glasgow Outcome Scale extended outcomes, scores between 5 and 8, which are favorable, patients with hypothermia actually did a little bit worse than those with the control group. So as of right now, we're still searching for a better strategy for using hypothermia other than just in tier 3. The other big news was progesterone and TBI. This was published in December 2014. It was a PROTECT 3 trial, and it was the preclinical trials, at least with PROTECT 2 and a trial from China, had suggested that progesterone may have some benefits. So progesterone is a neurosteroid hormone that actually has been shown in animal studies and preclinical human trials to have some effect in improvement with cerebral edema, improvement in behavioral skills as well, as decrease in neuronal loss in patients with TBI. So it was a pretty promising study. This was a very large multi-center trial, and progesterone was started infusing within 4 hours of TBI and continued for a period of 71 hours. Unfortunately, when you look at the overall data, there really was not a whole lot of significant improvement. In fact, if you look at the overall trends, placebo group actually ended up doing a little bit better than the progesterone group. There's a lot of reasons for this. TBI is a very multifactorial disease, and a lot of the patients that were included in the trial had moderate to severe TBI. And if you're not going to be able to get to a great rehab center, you're not going to rehab very well. So that's part of the reasons that people think this trial did not perhaps work as well. They're still doing further subgroup analysis to see if there is a role for progesterone in at least some patients. The last sort of topic I wanted to talk about is intracerebral hemorrhage. Typically, we see a CT scan like this with a patient with a subcortical hemorrhage, and there wasn't much that you could do for them. Surgical resection for these patients is hard. You have to go through a lot of normal white matter tracts and a lot of normal brain to try to remove the clot. Hemodynamic control has always been sort of a question. Sure, the systolic blood pressure should be targeted less than 180, less than 140. How do we reverse coagulopathy if there is something there? And what can we really do about that blood hemorrhage that's there? So, the management strategies for intracerebral hemorrhage, the biggest thing about these hemorrhages is that when they expand or when they occur, the highest chance of expansion is during the first few hours. So that's really important when hemodynamic control is really important. And if there is some sort of coagulopathy or active extravasation, ongoing bleeding, to control it during that time. So the first portion of it is blood pressure control. We recently completed a study attached to which looked at systolic blood pressure control versus less than 140 versus less than 180. 1,000 patients were enrolled. The trial was stopped early. The investigator meeting was just last week. I was hoping we would have some results by today, but we don't. But certainly keep an eye out for that. Hopefully it will give us some new information to see if acute hypertensive control will help at a higher target. The other important trial to sort of, which is also completed, but is not yet published, but should be published in the next few months, is the Stop It trial, because we borrow a lot of acronyms. But the Stop It trial in neurocritical care is this idea that when you have a, see if I can use this here, a thalamic hemorrhage or a subcortical hemorrhage or any sort of intracerebral hemorrhage, to sort of look for active bleeding. So most of these patients, when they come in through the emergency room, are going to get some kind of vascular imaging study to rule out a underlying vascular malformation. So the CTA is done, and then you do delayed imaging. And if you see a little bit of hyperdense material or contrast extravasation into the hematoma itself, that's considered a sign of active bleeding. So the Stop It trial has been looking at the addition of recombinant factor VII in these patients to see if there's going to be a role for that. The trial is completed, but the results have not yet been made available. But that's something to certainly look out for. And the final portion of ICH, at least, is looking at mass effect and clot evacuation. So a lot of times, as I said before, we had these subcortical hemorrhages that we're not able to do much for in terms of clot evacuation, as they're just too deep. A clinical trial called MISTY-2 and ISIS was completed in 2013, and at least preliminary data at that time suggested that minimally invasive endoscopic surgery may have a benefit in removing clot evacuation, as you see in the postoperative image. The problem with this was at the time it was an extremely cumbersome device. A lot of neurosurgeons were not adequately trained to use it. More modern device is coming into play. It's called the NICO device, and it's going to be a brain path trial. We've sort of been using it at Emory and Grady on a preclinical basis so far, and the results have been really astounding. This decreases the amount of time that they're on the ventilator, they get extubated faster, it decreases the risk of aspiration, and their ICU time. So this is something to certainly keep looking forward to as time goes on. And the other major trial that was released this year is for intraventricular hemorrhage. So a fair amount of patients have isolated intraventricular hemorrhage or will have hemorrhage, subcortical hemorrhage or thalamic hemorrhage associated with intraventricular extension. And what we do with these patients is that they need CSF diversion. The question has been that does the addition of intraventricular TPA, is that going to help improve outcomes and improve clearing of the hematoma in the ventricular system? So the CLEAR-3 results, which came out earlier this year, showed that the dose of TPA that was given was 1 milligram Q8 up to 12 doses. Patients were enrolled within 12 to 72 hours after intraventricular hemorrhage or subcortical hemorrhage with intraventricular extension. They enrolled 500 patients. Their modified rank and target was functional independence, and they were both very similar, 48% versus 45% improvement at that point. There was a slight reduction in mortality of 10% in those patients that did receive intraventricular TPAs compared to the placebo or the normal saline group. The likelihood of a good outcome increased with the amount of blood that was removed, but it was not statistically significant. They did find, however, that if you had a small intraventricular hemorrhage less than 20 milliliters, there was no benefit for IV TPA. So this is a practice that we've been using a fair amount already, and it confirms our utility of this intraventricular TPA for patients with very large amounts of blood in their ventricular system. The last sort of bit I have to talk about, I think, is neurocritical care is a field that's sort of still very new and still kind of finding its way in terms of research. I think for the next year, the things to really look out for are going to be what we can do for patients with wake-up stroke. I think the next step with traumatic brain injury is going to be multimodal monitoring to really help use microdialysis and other techniques to help improve these patients if we can. And then in terms of intracerebral hemorrhage, hopefully more clot evacuation trials with the brain path trial, and as well as keeping out an eye for the results of ATTACH-2 and the STOP-IT trial. I'd be happy to take any questions.